Burnout's an important problem due to chronic workload excess, which the WHO has now classified as a specific syndrome. For someone suffering from burnout, the standard approach is for resilience training after the harm has occurred, yet the fundamental systemic problems that create burnout invariably remain unaddressed. And we must not be deceived into thinking mindfulness and relaxation are panaceas for burnout. Action is also needed to tackle the root cause of burnout. Otherwise, the victim may be unfairly blamed for something that is actually beyond his or her control. Colleagues we may regard as good practitioners often have character attributes such as compassion, high performance standards, and a commitment to patient care. These qualities are endorsed by patients and employers, yet specialists who possess them may be more vulnerable to burnout. And it's no secret that DHBs routinely use clinicians' goodwill to compensate for systemic underfunding and inadequate staffing, and tacitly reinforce such altruistic behaviour through things like Employee of the Month schemes. Endemic under-resourcing creates an institutional culture of dependence in DHBs, and the main burden of which falls squarely upon those who are motivated to go the extra mile. An expectation of goodwill from doctors all too readily descends into exploitation. So in this context, I think resilience coaching is simply palliative relief for an ailing system, but without treating the underlying malady. Comprehensive measures to prevent burnout are essential rather than relying on treating sufferers after it occurs. Even if unintended, DHBs must avoid implying that funding constraints make burnout prevention impossible, or that when burnout occurs, the only solution is for doctors to get better at relaxing. DHBs have a duty of care to employees to make the workplace safe and caseloads manageable, and this duty of care cannot be shirked.